Okay, so pregnancy and substance use disorder and why this matters so much. I mean, I think we all know, recognize, kind of viscerally feel ourselves that women who have substance use disorder, the medications that we use and using those during pregnancy, there's a lot of feels that go into this. There's a lot of emotion. There's a lot of studies. There's a lot of evidence. There's a lot of the way we interpretate, make up words. Maybe that was a Freudian slip. The way we interpret the data and the studies that we have sometimes to fit our own ends. It is rich with controversial content. Let's just say that much. But I think part of that is because it matters so much, because we're thinking about little ones, right? And we all get very emotional and tied into the potential of these little bitties that are growing and developing, and how we're possibly impacting their future. But I kind of want to take a step back a little bit and look at some of the bigger pictures around pregnancy and substance use disorder. Oh yeah, me, your presenter. And I don't have any disclosures of any real interest or application. So what I want to do today, by taking that kind of step back a little bit and thinking about substance use disorder in the setting of a pregnant human being, is to increase our awareness of upstream contributions to downstream challenges that are related to women in substance use disorder. So when we see a woman who is pregnant and has substance use disorder, it's not like both those things just happened, right? Like there's a lot that went into her life prior to her presenting to us with a positive pregnancy test and discussing her substance use disorder concerns. So understanding the impacts of our external environment, on this individual that's in front of us, on the development of vulnerability to substance use disorder, and then connect how our role extends beyond the four walls to promote prevention and of the development of substance use disorder. So 4 walls of our clinic, whatever space it is we do our work in, usually has about 4, maybe more walls, but there's a whole world outside of our walls, and understand how we connect to that. So just to say some things and get it out there and move on from this, because it almost seems like we often just start with this information and don't go much further in our discussion than this. So there are a number of very learned colleges, organizations, agencies that do have papers, documents, evidence, studies that discourage tapering or cessation of medication for opioid use disorder, opioid agonists during pregnancy or after delivery. The attempt to avoid neonatal abstinence syndrome or neonatal opioid withdrawal syndrome is not a reason to cease medication-assisted treatment, or, as I hope we just start saying one day, medication. Neonatal abstinence syndrome, because it's abstinence from a substance. It could be many different substances. So anything from stimulants, which let's go ahead and call it nicotine, caffeine, those things do impact the growing fetus, and withdrawal from those substances happens. And forgetting that that is part of the concoction that can cause abstinence syndrome in neonates, we're kind of doing a disservice to mom and the baby, because some of the ways in which those withdrawal syndromes in kiddos look, it can look similar to opioid withdrawal, and they happen sooner, especially when a mom is on a long-acting agent of an opioid. So nicotine, caffeine, methamphetamine, cocaine, gabapentinoids, SSRIs, opioids, benzodiazepines, and alcohol. All of these things consumed, used in pregnancy can cause a withdrawal syndrome in the neonate. So when we talk about NAS, just as the name implies, it is abstinence from a or multiple substances that the neonate is dependent upon. Neonates are not capable of addiction or being addicted to a substance, because addiction is a behavior. Physiologic dependence is exactly what we're seeing in the neonate, not addiction. So as we currently understand the evidence, and I recognize evidence changes, there's more and more every day. We all try to do the best we can with the evidence at hand. So as we currently understand the evidence, like what we have, opioid agonists are gold standard treatment for opioid use disorder in the pregnant patient. And we do not currently have enough evidence to safely endorse naltrexone, as we don't know the long-term impact of opioid antagonists on brain development. So when you just think about an antagonist, it's blocking that mu receptor in the fetal development growth period. What happens when your mu receptors are blocked as your brain is developing? I don't know. And many researchers don't know either. So it's something that is being evaluated. We just don't know yet. It may turn out to be the holy grail, and that's what we all need to be doing, but we don't know that yet. Neglected substances, I kind of beat up on this a minute ago. Tobacco, nicotine, a lot of women who are pregnant smoke or vape. And we know this, and we seem to not put as much emphasis on this as I think we need to, because exposure to nicotine and tobacco products in utero sets you up for a whole bunch of other things, including low birth weight, premature delivery. Those are important. Cannabis use and development of the brain and cognitive function, alcohol with fetal alcohol spectrum disorder. That has a huge impact on mental functioning and development of our young kiddos that will carry with them into their adulthood. So we need to be paying close attention to all substances and not just the ones everybody seems to be talking about. Recognizing the impact of substance use disorder, opioid use disorder, the impact of these conditions was present prior to the pregnancy and will continue to be far-reaching into the future lives of both the mama and her baby. So looking at that big picture. So when we have a pregnant mama in front of us who has an opioid or a substance use disorder, it didn't just happen the moment she peed on that stick and it turned positive. This was something that was happening in her life prior to becoming pregnant. It is something that will still be a part of her life, even if she's in sustained recovery. It's part of her story. And we need to keep that in mind and never discount the gravity of this condition and when it can revert and we see somebody having return to use. Supporting someone who has history of or active substance use disorder is part of that bigger picture. There's much more at stake than what we put on a prescription pad. What we put on that prescription pad definitely has impact, and we need to be aware of that and provide education around that. But there's way more happening than just what we're prescribing for our patients, pregnant or not. So this is, I'm not doing this because I'll fub it, I know it. So this is a link to a little video snippet from a woman named Barbara Frank. I think that's on my phone, but I can't read it right now. I can't read her name. I think it's not Barbara, Deborah Frank. She's a developmental pediatrician out of Boston University. And it's this funny little clip of her at a conference. It's just funny because it was done in the 2000s and it seriously looks like it was done in 1983. But it wasn't. So she's talking about a mystery drug, and it's a substance that causes intrauterine growth restriction. There's a high likelihood, especially of females exposed to this in utero, of going on and developing this same substance use disorder. It is associated with cognitive function, executive function issues, and it carries forward with people as they head into elementary school. Like this drug has impact on the fetus, its growth and development, and you can see it in young children and older kids as well. And then with the increased chance of having the same substance use disorder, and this substance is also connected to high morbidity and mortality. And then she goes on to talk about what would you do if you knew that a mother was using this substance during her pregnancy and knowing that it has such detrimental effect on the neonate and young developing child and into adulthood. What would you do? Would you put her in jail? Would you do, what would you do? What would you do with the child? Would you advise a family member like, yeah, it would be fine if you adopted a kid exposed to this substance? Well, it turns out the substance she's talking about, you guys are probably already clued in on it because you're a smart crowd. It's nicotine. So just kind of putting some things in reference and perspective, how we seem to be focused on a substance, and that's the chemical, instead of the substance that is the material of the individual's lives that are in front of us, and the decisions that they make and how we support them in making the decisions that they make and how that impacts their lives long term. So I'm going to tell you about a few patients that I've had, and just FYI, I am going to let this presentation, I'm going to shorten it compared to what the actual slide set let me do, because I've got a number of slides in here. But I do not have a case, so I'm not anticipating really rushing this, and I want to have an opportunity to talk about it. So I'm not planning on pumping you guys for a case presentation when I'm done with this. So I'm going to take a minute to go through these, but not as many minutes as I could, I promise. So this is a patient of mine from when I was in New Mexico. Lordsburg is a town that is, can't remember if it's, I think my town was 75 miles from the border. Lordsburg was probably like 15 miles from the Mexican border. And this patient in particular, 20-year-old female, she was regal. She just held herself in a very queenly fashion. She was absolutely gorgeous, just very forthright, very comfortable in her own body, but not at the same time. So that's why she's the Lordsburg queen. 20-year-old presenting for prenatal care via the Lordsburg Detention Center. So she was incarcerated when I first met her. And, well, yeah, through her whole story. G1P0, so this was her first baby. And she got her first prenatal care early second trimester, so around 17 weeks. She had been put in the detention center and had been withdrawing. She was using heroin. I think she was probably smoking it. I don't remember that she was injecting. But she'd been using heroin and was put in the detention center for a probation violation. She told them she was pregnant. She did the whole withdrawal bit in the detention center. And it took several days before they brought her to medical attention. So confirmed the pregnancy, got her started on prenatal care when I saw her in clinic. But every single crime she had were all substance related. The original charge, and she continued to get probation violations, which is why she was in and out of the detention center, was for contributing to the delinquency of a minor. I think she had been drinking when she was 18. Her crime was drinking with someone when she was 18 and the other person was 17. She was the only one in the group charged. She was not the only adult, but she was the only one that carried charges. So it feels sort of weird, right? But unfortunately, this is not an uncommon story. Justice is blind, not in the way we need her to be blind. All of her OB visits, she came shackled, ankles and wrists bound. She had chains on. None of her crimes were violent, not a one. None of her probation violation was related to any violence, but she was shackled every time she came in her little orange jumpsuit with her growing belly. I could hear her coming down the hall because it would clank on the linoleum floor. So she had detoxed in the detention center, but she was having incredibly strong cravings. We talked about what her options were, what she wanted to do. She'd never been on buprenorphine, but she wanted to start it. So that is what we did. Titrated her up, stabilized her on 16 milligrams. Granted, it's a detention center, but it was a controlled environment. It's a small facility, and I actually don't think they had other substances coming in. Maybe they did, maybe they didn't. She wasn't getting them. She always tested appropriately when I checked specimens on her. It was always just buprenorphine she was positive for, no THC, no nothing else. She also had her medication controlled. So they had the prescription in the detention center and they would give it to her. As she settled out, no more cravings, started, coming into her own. She was very vibrant and engaging. And one of the wardens who started consistently bringing her in, you kind of saw a little friendship strike up between them. And after that happened, she wasn't coming in shackles anymore, or there would just be the wrist ones and not the ankle ones. So there was definitely a little bit of a bond happening. The warden was an older female as well. So a little bit more of a motherly feel between her and this particular warden, and started to back off on some of the just ridiculousness that I'd seen from the very beginning. So she came into labor and delivery at 37 weeks. Prior to here, when I worked in New Mexico, I did full scope care, including addiction care. So I was providing her prenatal care and her substance use disorder treatment. So I was on call, came in with her at 37 weeks because she was having contractions and her cervix was changing. A couple of weeks before her presentation to labor and delivery, I had diagnosed primary HSV outbreak. So she had a primary outbreak of herpes and was on medication, but the lesions had not fully cleared. And for that reason, that's an indication for C-section. We do not want to have a vaginal delivery when we have active HSV lesions. And she had this beautiful, beautiful little baby boy. I was in a very small hospital. We did not have a NICU. At best, we had like a level 2 nursery. And because, I don't know, the people there kind of let me do what I wanted to, and I'm a little spoiled with that, I'll be honest. I'm like, hey guys, let's just try eat, sleep, console for this kiddo. And so I got the nurses on board with my idea, and we didn't have a policy for it, but I'm like, let's try it and see what we can do. That's exactly what we did. She breastfed. She was a champ at breastfeeding. We did not have to use morphine at all. And then when we did, because she left, she was discharged. We were still monitoring him. We did that 96-hour observation. She was discharged, and she was actually, a friend came by and took her out for a steak dinner and took her shopping. She didn't have any stuff for the baby, and she was gone for several hours. Okay, she got to wear normal people clothes, and she wasn't shackled because they had put her kind of almost like on a break from her time served. So while she was in the hospital, she was kind of hours, and she got to go out. And during that time, his scores jumped up, and he did require 2 small doses of morphine. But once she was back to the hospital and breastfeeding, we did not have to use any more morphine in her little one. So this gets at this eat, sleep, console model and why it is so effective. Lights were kept low in her room. It was just her in the room. It would be usually one person at the most in the room aside from her, engaging with her and the baby. We did not take the baby out of the room. All of my newborn assessments were done in the room with her and the baby. Finnegan scoring happened in the room with her and the baby. You assess the kiddo as far as any withdrawal symptoms based on how well are we able to console the kiddo? Is the baby able to sleep? And it's up to, I think, about 2 hours. You want to see that they're able to sleep for 2 consecutive hours. And then are they eating effectively? So effective suck. We don't see excessive weight loss. Breastfed babies lose weight, period, which is, it's a thing we need to accept and move on with life. They lose weight. All babies lose weight, even formula fed babies. But breastfed babies tend to lose weight for a little bit longer period because we're waiting on milk to come in. But if we are suckling at breast, mom's not having pain, and we're not seeing rapid weight loss, and we're not getting over 10%, and we've got an effective suck, then baby is effectively eating. The time spent breastfeeding, the skin-to-skin contact, following baby's cues for needs, I'll encourage treating mother as baby's medicine. And then what I've described with that rooming in practice where mom's right there with babe, she's observing baby's cues and answering them, and then all non-pharmacologic interventions employed first. So things like skin-to-skin, shushing, swaddling, swaying, sucking. There are lots of ways to engage with infants and provide soothing that does not require medication. So in leaning on those first, and when none of that is working, yes, we will turn to pharmacologics. So when you do that, it does result in significant reduction in length of stay, significant reduction in the opioid agonists used to treat withdrawal symptoms, as well as the period of time that you need to use them. And then buprenorphine, and I've put the molecular weight here because that's important. Anything over 500 Daltons is too big to pass through into the breast milk. So buprenorphine is 504. That part is documented. The next part of the statement after the comma is kind of mine. The buprenorphine isn't passing into the milk. So there's something else that's happening. It's not medicine in the milk that's treating the baby's withdrawal symptoms. So whenever people tell you like, well, it's because they're breastfeeding and they're getting medicine in the milk, that's not it. So just I'm leaving you with this statement. That's not it. Okay. I won't belabor it anymore. All right. So she had the baby. It was awesome, except for when she had her steak dinner. We had to use the morphine, but other than that, we didn't have to use any more. She did get a reprieve of her sentencing. She just had a baby, so let's send her home with her baby. And she was placed on house arrest, so she had some nice ankle jewelry. She was in Lordsburg. She was with her mother. That was not a good relationship. Lordsburg, there's nothing there. There really is nothing there. There's a bunch of stuff that looks like it's condemned, but it's not. I was actually going online to see if I could find some pictures. I couldn't find any of my personal pictures of Lordsburg. But all the pictures I found online made it look really kind of quaint and fun, like a ghost town. I'm like, that is not what Lordsburg looks like. It looks a lot like what you see when you cross from El Paso into Juarez on a smaller scale. There's not a lot of resources there. Because of the distance to resources and a safer, healthier community, she returned to jail. Not surprisingly, right? The odds are stacked against her. Baby ended up with maternal grandmother, and then they were lost to follow up with me. So I don't know what ended up happening there. curious, but don't know. So our war on drugs is causing a significant rise in the number of women who've been incarcerated, and really gets in the way of their ability to access adequate drug treatment. 40% of criminal convictions leading to incarceration of women just in the year 2000 alone were for drug-related crimes. 34% were nonviolent. 18 of women in prison have been convicted because of violent contact, so a small number. And then 7% public offenses, many of them related to things associated with substance use. And then we take another look. Women of color are significantly overrepresented in the criminal justice system. Between Black and Hispanic women, when you look at the numbers of these women who are in the justice system, that percentage is much higher than their representation in the general population. Something stinks in Denmark. Just the number of people imprisoned, and the slide on the left with the red bars is anybody. We look at 1980, comparing it to 2019. It was super the wrong direction. We need to see that going. And then the purple bars are related to women in state and federal prisons. Again, 1980, looking at 2019, we've had an explosion. I was sharing these slides with somebody else, and someone else pointed out that we also had privatization of our prison and jail system during this time period as well. So people are making money off of this. Of female state prisoners, 2/3 are mothers of a minor child. 1.5 million children have a parent, father, mother, one other or both, in prison. And more than 8.3 million children have a parent under correctional supervision. And more than 1 in 5 of these children is under 5 years old. The Welfare Reform Act bans people with felony drug convictions from federal cash assistance and food stamp programs. There's a whole bunch of words here in the middle. Basically, all the systems that are in place that we have to help people with access to food. TANF is something that helps support childcare services. There's a lot of really nice services through TANF. And actually, here in the state of Tennessee, you don't just have to have a felony drug charge, you just need to have a drug charge conviction. So it can get even beyond just a felony conviction. You have access to these services restricted, and we know that restrictions from these services, it actually, if you read between the lines here a little bit, it is going to increase the likelihood that children are taken from these homes because people don't have access to things that help keep their children in home. So if recidivism increases, justice involved individuals are not able to meet their children's basic needs. You have a neglect situation, right? DCS is involved, the children are removed from the home. So we've already had parent out of the home because of conviction. Then we have parents not able to maintain their roles as parents because these children end up in situations where they're not being supported the way they need in the home, but it is related to the parents' judicial involvement that keeps them out of programs that would allow the parents to do a better job, stay out of jail or prison, and provide for their children. So all of that is to say multiple factors outside of one's own control can greatly contribute to increased exposure and vulnerability to chronic stress. Chronic exposure to stressors leads to overactivation of the body's stress response. And no, do not worry, I'm not going to give you a neurology talk right now. I'm not going to do it. But it interferes with functions such as the reward pathways in the brain, so that hijacking of how our brains function and decisions that we make, having executive function online, kind of online or not online at all, are impacted greatly. Social determinants of health that generate and support chronic and prolonged stressors are predictive of substance use disorders, such as concentrated poverty. I like this phrase, systematically thwarted opportunities, breed discrimination, right? So when we have systemic discrimination, like I was just pointing out, women of color ending up in the judicial system at higher rates than represented by their just general population presence, discrimination may be afoot. Incarceration, loss or separation from parent at an early age. So between incarceration, DCS involvement, loss or separation of a parent from an early age, overdose, fatal, loss of a parent at an early age, emotional, physical, or sexual trauma, parental divorce, conflict, neglect, isolation, food and housing insecurity. All of these are chronic stressors that just prime the pump for the likelihood, potential for developing a substance use disorder. Stress response, it activates a lot of things in the body. And there was a study, the references are at the end. Thank God we put them at the end because I can't remember what study this came out of, but my reference slide at the end does, so you can refer to that. But there was a study that they did that looked at, they basically intentionally activated a stress response in individuals with history of substance use disorder, in this situation, alcohol use disorder, and linked it to craving of substances. So exposed to stressor, and then they measured the next day alcohol intake, and there was a link. When exposed to stressors, next day alcohol intake, there was an uptick. Then there was a study, this actually is not the Rat Park study, it's another study. You guys can just Google Rat Park. It's a fun little video that you can find that kind of goes through how that works. Substance exposed, socially deprived rats chose interaction over substance. So we've got chronically stressed rats who've been exposed to substances, but when they get the opportunity to engage and decrease the social isolation, they chose to do that rather than accessing the substance that was also readily available. We do a lot of rat studies and extrapolate it to humans, so it's nothing new for me to bring in rat comparisons. So those slides just kind of putting together saying that my Lordsburg queen came from a place that had her in a situation where she was high risk for developing opioid use disorder. She did, she had it, she got pregnant. And what happened subsequently in her life was a direct correlation of all the stressors she had experienced early on. And the baby that she grew and who was removed from her care is now at high risk for developing a substance use disorder as well. My next patient had history of childhood trauma, largely in the form of bullying. She started using substances in high school. Her use escalated. That escalation of use resulted in her selling drugs. She did engage in prostitution. She'd been in jail. She'd had trauma, yes, and trauma as an adult. She experienced gang rape, kidnapping, and torture. Not anything anybody you know, love, or even just stand next to you on the bus do you want them to have ever experienced. At some point in her dysregulated life, she recognized that she was pregnant. At that time, she was buying buprenorphine and smoking methamphetamine. So she was using both buprenorphine and methamphetamine. She did seek care at a clinic for prenatal care, but also a clinic where she could get opioid use disorder management as well. So she was getting that lovely go one place, get all your cares addressed. She was being tapered. She was taking about 16 milligrams when she could get it. That's about what she was buying on a daily basis. So she was being tapered with the goal of cessation of buprenorphine during a pregnancy, but she began having frequent methamphetamine positive drug screens in the clinic and just disclosed to the group that was caring for her that she was not tolerating the taper well. During the taper, she had actually been going out and buying supplemental buprenorphine, which also exposed her to meth. And so while you're buying your bupe, maybe they gave you a deal on some meth, but she'd walk away with both and using the methamphetamine to kind of help with the buprenorphine cravings and some of the withdrawal she was still experiencing because she was not on a dose that had her feeling very stable. She transferred into our clinic here because of the methamphetamine positive urine drug screen. So we started working with her on addressing her methamphetamine use and that's how we discovered the supplemental buprenorphine doses and got a history that gave us the dose that she was achieving on a daily basis and started at that dose. So we stopped the taper and then continued to titrate the dose of buprenorphine so that her opioid cravings were controlled. And then we focused on behavioral health interventions that would address the cravings for meth, because that is our current best intervention for methamphetamine use disorder is behavioral health interventions. She quickly engaged in counseling services anywhere, everywhere. At some point in time, it was almost like, I think you might be using too many services because you're going to meetings that are like overlapping one another and you seem very overwhelmed. But she was like a house on fire trying to get herself the services that she needed. She did have a period of time of grieving and really tried to connect with new friends because the friends she'd had previously were ones that she knew she would return to use with. And then she started connecting with some mothers in the groups that she attended, which the first group of mothers she connected with actually resulted in a return to use episode because they all wanted to go get high after their mother's group. And then she found a different mother's group where that was not what was going on. The stressor that came up during her care with us after baby delivered was that the cord tested positive for methamphetamine, and the baby's maternal grandparents, so my patient's parents, were awarded custody of the child. Fast forward 2 years, because of that cord positive, she was reported to the state, and they were going to list her on the state registry for child abuse and neglect. And it was the cord finding alone that was going to get her on that list. She was able to appeal it, and she's not on that list, thankfully, because she didn't need to be on that list. She does have an unrestricted driver's license at this time. She's got a car that runs. She's on her second job where they keep asking her to be a manager, and she's like, I want to do something else. I don't know that I want to be your manager. But she transitioned from one job to a higher paying job, and she now has full custody of her child. She's completed her training, is working on hours to get fully certified as a certified peer recovery specialist. And that's, I think, where she wants to put her energy instead of becoming a manager at the deli at the grocery store where she currently works. So her case I want to use to emphasize the energy we spend talking about, thinking about, agonizing over the substance, meaning the chemical, and not the substance of our patients' lives and the experience they're having as they walk this earth. Because we tend to talk a lot about, are they diverting it? Are they taking it as prescribed? Is the UDS really what's there? What's going on? How am I collecting it? Do I need to watch them? What am I doing? I think we serve ourselves and our patients a lot better when we focus on our patients. Are they keeping appointments? Do we see that they're progressing through milestones like probation requirements are being met? DCS is starting to slide back. They now have unsupervised visitation. They've gotten full custody back. They've got a job. They're keeping a job. What is the behavior that our patients are displaying for us when they come? Are they engaging in services, counseling? Rather than what's happening on their urine drug screen. Our patients are so much more than pee and what's in it. So when we also think about the children that our patients once were and the children that they themselves are having, children confronted with childhood adversity and have a safe, stable, nurturing relationship. Sorry, this stuff gets to me. With at least one adult fosters positive outcomes. So if we can help their parent move into a place they can be that safe, stable, nurturing place, we have made a difference in the ability for these children not to have a substance use disorder themselves. That's why this is so important. Sorry. And why it's more than what we put on a prescription. Many of these women that we work with develop their substance use disorder proclivity likely when they themselves were in the womb. So their mamas may have experienced trauma, toxic stress, may have come from a family with substance use disorder, or female themselves may have been in abusive situations, been afflicted by poverty, did not have access to supportive interventions. So we need to back up and think about way more than what prescriptions our mothers are on. It's risk versus benefit. And we've got to make certain we are taking care of the generation in front of us and the generations that are yet to come. And the